Basically, going to talk about the screening for AAA. So in terms of what our objectives are tonight, basically just kind of four main topics that we can fit in 10 minutes. I wanted to review quickly the abdominal aortic aneurysm risks, natural history, and the treatments. Review the USPSTF. I'm just going to call that the task force from now on because I can't say USPSTF very well. And the Canadian recommendations regarding screening, because those things are sort of out there, and not only with aneurysms, but other forms of, or other types of diseases. Those things kind of come into play with reimbursement and what have you. Also want to determine whether and how we should screen for abdominal aortic aneurysms and understand which patients we should be doing this with. So, definition of a AAA. Basic thing, what is a AAA? It's defined as an aortic diameter of greater than 3 centimeters, and most commonly, obviously, as incidence increases with age. Risk factors for AAA. Basically looking at odds ratios, things that you want to keep a lookout for in your everyday practice. And this is from a aneurysm detection and management study that was done many years ago. But the big one, as most of us know, is smoking. The odds ratio having that about 5.57, so that's pretty high. So somebody who's a smoker, most of these patients have a history of smoking in the past or currently. Males have a much higher predilection for having aneurysms as opposed to females. Family history plays into it, so there's probably some genetic factors that we have to identify. Whites versus African Americans. Whites do tend to get them more commonly, about double their rate. Atherosclerosis, very common, hypertension, and what is interesting is that diabetes seems to be somewhat quote-unquote protective. So that's one bad thing that they don't tend to get as much as other people do. Other things that were kind of related, all age, height, hyperlipidemia are also associated, but the smoking-related risks explains the vast majority of these patients, and they looked at a lot of patients, about 73,000 people. So these are the things kind of to keep an eye on in your everyday practice. In terms of prevalence, again, looking at smoking, so for patients who never smoked, their rate is obviously going to be much lower, particularly as when you're at the younger spectrum, anywhere from 50 to 54, their rates are very, very low. If you don't smoke, you're probably not going to get AAA at age 50 to 54. But as we carry that out towards the older age groups, up when you're 75 years old, if you have smoked, your rate of aneurysm is going to be much higher than that of a non-smoker. In terms of patients having aneurysms 3 centimeters or larger, and this was in a study of veterans groups, they're usually a somewhat homogeneous group that they can kind of get together and look at them as a population. Prevalence of AAAs with aneurysms 3 centimeters or larger in vets of 50 to 79%. They looked at this if they were a current smoker. They screened almost 23,000 patients. Over 6% of those people had AAAs. If they were a former smoker, it was a little bit lower. And if they never smoked, it's much lower at 1.6% compared to 6.3%. So there's obviously smoking plays into this. In women, it's kind of interesting as well because women tend to get aneurysms much less than males. And even when they smoke, their rate was only 1.5% compared to males. So obviously, smoking cessation is something which would take care of a lot of these patients. In terms of risk of rupture, it varies based on the size. And when you have an aneurysm which is 4 centimeters or less, or 4 to 4.9 centimeters, they have about a 5% risk of rupture at a given moment in time. As the aneurysm gets larger, you can see that your rates of rupture go up tremendously. And when you get up to 6 and 7 centimeter aneurysms, very big aneurysms, the risk of rupture is quite high. So this is something. I don't have that with me right now. In terms of rates of growth, smaller aneurysms grow at a slower rate, but they will tend to grow. And as you can see, when you go from 2.8 or to 3.9, they grow at about 0.2 centimeters per year. But as you get bigger, they tend to accelerate their growth. And smoking, if a person is an active smoker, that rate of increase is higher. It's estimated that anywhere between 20 and 25% rate, you're increasing your rate of growth. So smoking cessation, again, even in a patient with an established aneurysm, is very important. So in terms of the natural history, elective repair is considered for aneurysms bigger than 5.5. I think that's variable. That's sort of naive general rule. I think if you ask vascular surgeons in the room, some people would have different criteria or ways that they deal with these than others. But in general, if they're bigger than 5.5, you certainly want to operate on those. I think that most people that we see in this community probably have them operate on when they were somewhat smaller. That's been my experience and what I see. Also, if these aneurysms, if they're following these aneurysms, they've gotten bigger by half a centimeter in 6 months. That's somebody that you really need to keep an eye on. You probably want to get to the OR sooner rather than later. Any patient with an aneurysm who's symptomatic with back pain, any complications such as distal embolization, that's somebody who should be examined for repair on a more urgent basis rather than pushing it down the road. So going back to our objectives, now we're going to look at the task force recommendations about screening. So in 1996, the task force basically recommended that there is, or basically stated that there is insufficient evidence to recommend for or against routine screening of asymptomatic adults for a AAA with either abdominal palpation or ultrasound. That's great. That really helps us. So before or after, what do we do, right? What's the right answer? So that was not helpful. In 1994, a couple of years before that, the Canadian task force basically said there is insufficient evidence to recommend for or against screening with physical exam or ultrasound, and the prudent physician may choose to include a targeted physical exam for aneurysms in males over 60 in the periodic health examination. Sort of paralleling what the U.S. task force said, not too helpful there. The task force also makes other recommendations about carotid ultrasound, about peripheral arterial disease, basically stating that there's insufficient evidence to recommend for or against with carotids. As for PAD, routine screening for PAD in asymptomatic persons is not recommended currently. So these things are sort of out there in the milieu, and I think, you know, most of us have a certain sense of what they actually see out in practice. So now we want to kind of talk about determining whether and how we should screen for these. So just in general, going back to 1975, I looked at, you know, what is a good screening test? What makes a good screening test? Basically, adapted from Freeman Carlson Journal of Family Practice, they kind of looked at this and figured out what's the right thing to do about screening. Basically, you want to look for stuff that you can detect in treatment of the disease before symptoms appear, but you have to have your end result, or your result must end up in lower morbidity and mortality than the treatment after the symptoms appear. It has to be an effective treatment, and should be based upon randomized controlled trials. And screening has to be somewhat non-invasive, something which is, you know, I could put a patient through an exploratory laparotomy for screening. Okay, that's not a screening test. That has to be an acceptable test to the patient that's very simple and common and available. So why, when you ask yourself, why are we talking about this? Why would you want to screen for AAA at all? Well, only about 18% of patients with ruptured AAAs reach the hospital and survive surgery. So it's probably a pretty good reason, because that's not an uncommon problem that we see. AAAs enhance over time, they enlarge over time, and once they're 5 centimeters in diameter, they have a pretty high risk of rupture, like we stated previously. And in the U.S., it's the 10th most common cause of death for an individual over 55. So in the top 10, that's getting up there, and that's something we really need to look at. In terms of mortality with AAA, elective repair of AAA is performed with mortality rates averaging less than 5%. I think most of the stuff I saw was probably weighted from 2, 4, 5% in that range. In the presence of a ruptured AAA, however, the surgical mortality is much higher, or has been stated in the past. This is now, we're talking about the whole number of patients that they were looking at in the past. So ruptured AAA is a really bad thing, so probably a good thing to screen for. So screening tests. Patient goes into their internist for their physical. Obviously, they get an abdominal exam, physical exam, and their doctor feels for palpation. And also, abdominal ultrasound is really the gold standard of how we screen for these. Looking at palpation and why it's probably not good enough, or it's not good enough, there were many studies done on it many years ago. It showed a sensitivity of 68%. That's not good enough. And a specificity of 75%. So if we felt this a pulsatile abdominal mass, it was probably an aneurysm, but there was a good chance it might not be. So palpation is obviously not good enough. Your sensitivity obviously increases when you have a bigger aneurysm. It's easier to feel it. It's easier to tell what's going on. However, now as we read the papers and you see all these news magazine shows and whatnot, obesity is a huge problem in this country. And the percentage of obese adults in this country is obviously getting bigger and bigger. So it's going to get even harder for us to tell with palpation on a general scale about what's going on. So it's something which is becoming more problematic. So now we get to kind of the topic of what I was asked to talk about, ultrasound screening. For anybody who does ultrasound, it's a pretty simple test. It's the aorta, you know where it is, you know how to find it. Barring any real large bowel gas or a patient with a really, really huge body habitus, most of the time you can identify the aorta and tell where it is and tell what it looks like. Obviously, there's no radiation, and the sensitivity and specificity are nearly 100%. It's a really good test, very simple screening test, and it's very cost effective. Looking at AAA screening, there have been 4 randomized trials done since the last set of task force recommendations, including about 125,000 men in this country, or 125,000 patients total, and they've now reported results of up to 5 years of follow-up. That's related to AAA. After they instituted screening in those populations were reduced by 28 to 68%. There was some range, but it's probably in the middle there somewhere, probably 40 to 50%. You reduced deaths related to AAA. That's a pretty good result as a result of screening. The largest of the 4 trials was the multi-center aneurysm screening study, or the MASS trial. And these trials were all reviewed in depth in the annals in September 2003. So just to summarize the MASS trial, the objective basically was to assess the cost effectiveness of ultrasound screening for AAA. It was a huge cohort, 68,000 men, aged right around that time where we probably have a higher incidence, but you start to see these patients that present with AAAs. And it was done in the UK. Death due to AAA complications or ruptures or what have you was reduced 42% in the screening group. And they had elective repairs if they got to 5.5 or greater in terms of their size. In terms of repeat screening, what did they say? Several screening programs have looked at this. The yield is very low, so when you have a patient that comes in, they get screened appropriately, and they don't have an aneurysm, repeat screening the yield is very low, so it's probably not something that you should or have to do. And basically, the yield is low. It was 0.1% in a decent size of veterans, tend to be higher rates of smoking, over 2,600 patients. So the repeat screening is probably not necessary based on the results of these studies. What about women? Randomized trial done with over 9,300 patients showed the incidence of rupture at 5 and 10 years was the same for the screened and for the control groups. So at this point, the data shows that there is no evidence that screening women is effective or necessary. And that's just the data that's out there. And again, some people might disagree with that, but that is what's out there right now. So from the task force, again, screening for AAA, their recommendation statement, go back. At this time, their recommendations are, they recommend a one-time screening ultrasound for AAA in men, not women, age 65 to 75, whoever smoked. 65 is the age that, in general, people hit Medicare coverage. At this time, they are offering no recommendation for men who never smoked. That's a C recommendation, so they're not making a recommendation for that at this point. And essentially, they're saying do not screen for AAA in women. They say there's no difference in terms of outcomes on those patients. In terms of current practice, what else is out there? Society of Vascular Surgery, Vascular Medicine, they have a consensus statement out there. And they basically have broadened their criteria for AAA screening eligibility. And it's a bit broader than the task force or the other randomized controlled trials, which the task force is working off of. Basically, they have said that men age 60 to 85 should be screened, regardless of other history, and also women who possess cardiovascular risk factors 60 to 85, or anyone greater than 50 with a family history of AAA, which is probably a good I think is a good subset of patients to screen as well. Just touching on Medicare, reimbursements, what have you, the SAVE Act passed several years ago. Basically, Medicare, which covers people over 65, we all know, doesn't include preventive services. So if they're going to cover one of those screening services, it requires an act of Congress. And good luck with that right now. After the U.S. PSTS task force report, Congress added a Medicare benefit for ultrasound AAA screening at the Welcome to Medicare visit. I didn't really know about the Welcome to Medicare visit. I'm not an internist, I'm an interventional radiologist, but I guess it's the visit that they get when you turn 65, you go see your doctor for your physical, and you get your, hey, welcome to Medicare visit. Basically, you're allowed to screen somebody during that 1 year that Medicare will pay for a AAA screening. And that's it. If you hit 66 and it's a day after, Medicare will not pay for it. So it's a very interesting, and I was not aware of that. And it basically covers male smokers and anyone with a family history of AAA. So, but the problem is, again, it's for men who smoke that are 65 to 66. It's a very narrow population. If those people are getting missed, then they're not going to get screened, at least on an official basis of how Medicare says that they will administrate this program. So what do we do now? What is the more practical way to approach this? I'm not sure, but I think we should be offering targeted screening for AAA. We have to follow the guidelines in terms of when those patients come for their Welcome to Medicare visit, they should be, or if the patient's in your practice and they come for their routine physical between 65 and 66, they have to be screened. They should be screened, especially if they have a history of smoking according to the guidelines. But reality, a lot of the patients that you have in your practice, they've had prior abdominal imaging of one sort or another. They might have had, a gallstone attack. They might have had a renal stone. They've had CAT scans, ultrasounds, you name it. And those studies, they provide a nice baseline for detection and for what I call pseudo screening. Every day I look at CAT scans, I look at ultrasounds, and we see the abdominal aorta in a lot of those patients. If you have a patient that falls outside those guidelines, or you have a patient that, they're 63, they've smoked, they have a 40-pack year, but they quit 10 years ago. Go back and make sure, look at their reports and say, oh, the aorta was okay, there was no aneurysm. At least you can get that, rather than sending for a test that, if it's done the way that Medicare wants you to do it, they may or may not pay for it. You don't want your patients to get mad at you. And when they get a bill from whatever practice they go to, if they go to see the vascular surgeon, they go to radiology, they go wherever, they may get upset, they get a bill for a screening test, which is not going to be covered. Patients and the physicians might desire that, but the current data recommendations are what they are, and you have to work within those parameters. From Medicare.gov, I thought this was interesting. This basically just states what we just said. This is right off, I literally cut and paste this off of their website. So they cover a one-time screening for ultrasound, but you have to get a referral from your doctor as a result of the Medicare visit, and who's eligible, the people we just talked about. So those are the only people that they will pay for. In terms of future directions, if the task force recommends AAA screening in a wider scope, health plans will probably follow coverage. Well, one thing I did forget to mention was that the private payers right now do not provide that screening coverage as well. So basically Medicare is the one payer at this point that will cover that. And I just want to thank you all for attention. Thank you.